Welcome, everyone, and thank you for joining us for the second webinar in our Spotlight series on quality of care. Those of you who already joined us last week will remember, and those of you joining this week will be interested to know that this webinar series was inspired by a comprehensive observatory study on different strategies to improve healthcare quality, which we published in 2019. My colleagues will post the link in the chat box for you if you're interested to find out more. We focused our webinar series on healthcare quality from the range of strategies that we identified that can contribute to quality of care by leaning on the father of quality assurance, Avidis Donabedian, and his structured process outcome framework for measuring and assuring quality of care. Last week, we focused on the inputs or structures of care, and we looked at health technology assessment and how it can help and contribute to quality of care. This week, we focus on the processes of care and clinical practice guidelines. And next week, we will look at how we can leverage outcomes in so-called pay-for-quality schemes or P4Q schemes. Now, on today's topic, we will be focusing on clinical practice guidelines, that is, as many of you will know, statements that provide recommendations to optimize patient care, ideally after systematically assessing the benefits and harms of alternative care options. And many countries have their own programs of developing such guidelines and disseminating them. Other countries do not, and so practitioners either look at guidelines that have been produced elsewhere or produced by European professional associations or international professional associations. Today, our focus will be on how we can link clinical practice guidelines to quality of care. So what can clinical guidelines contribute to improving healthcare quality? We will look at what we have been doing on clinical guidelines so far and what we can do and shall maybe do differently and perhaps better in the future. So how are we going to do this? We're going to have a keynote presentation on clinical practice guidelines and current best practice, followed by 3 spotlight speakers that will bring national, European, and international experience on a range of different issues, and a discussion with you. So to facilitate this discussion and to have as much interaction with you as possible, we ask you to use throughout the chat box function in Zoom that you all know very well by now. For your comments or your questions. We won't take questions after each of the presentations, but we will take them all during the discussion in the end. We will also use the chat box to paste some interesting links for you that you can click for more information if you want. And you can also use the chat box to do the same if you feel so inclined. So I think without further ado, I will introduce our speakers for today to give them also the maximum possible time to share their knowledge with us. We have an excellent group with us. For the keynote, we have Dr. Corinna Schäfer. Corinna is the Deputy Director of the German Agency for Quality in Medicine, where she heads the Department for Patient Information and for Evidence-Based Medicine and Guidelines. Corinna's keynote will be followed by a spotlight from Sophie Blanchard. Sorry, Sophie, for mispronouncing your name, from the Office of Clinical Guidelines at the French National Authority for Health, HAS. And during the COVID-19 pandemic, Sophie was a leader in providing urgently required guidelines to help Ministry of Health, but practitioners also in different areas deal with COVID-19 care. We then will hear from Dr. Gianpaolo Morgano, who works at the Joint Research Center of the European Commission, focusing on the initiatives on breast cancer and colorectal cancer and related guideline development, and who is a research methodologist trained at McMaster University. And we will finally wrap up our presentations with, last but not least, Dr. Per Olav Vantvik, who is an adjunct professor at the University of Oslo, but is also one of the founders of the MAGIC Research and Innovation Program, aiming to provide clinicians and patients with trustworthy evidence summaries, guidelines, and decision-making aids at the point of care. So as you can see, all very, very relevant expertise for our topic today. Before passing to you, Corinna, for the keynote, I would like to animate our participants a little bit. So I will pass to my colleague, Erica Richardson, who will introduce a poll question for all of you. Erica, over to you.
Thank you very much. Annalisa, could you please launch the poll? Brilliant. So just a couple of questions to see where we are with you as an audience. The first one is, does the country where you work have its own established guideline development program? And that's a simple yes or no answer. And the second one is to see sort of where we're all working. In the course of your professional career, have you used a clinical practice guideline to make clinical decisions, used a clinical practice guideline to inform other types, developed clinical practice guidelines yourself, all of the above or none of the above? And we'll give the results of the poll after Karina's keynote speech. But just to check in with you to see where you are. Thank you very much.
Thank you very much, Erica. I think we can see the results in real time, but if you want to keep a little bit of suspense for our participants, hold off until we've heard from Karina and focus on her keynote. So Karina, thank you very much for joining us. Over to you for your presentation.
Thank you for the invitation to be here today. My conflicts of interest, none of them relevant in financial terms. However, I mark the green one. I get paid for producing guidelines. This is why I think they're pretty useful. But just to give you a short flavor where I'm coming from, I'll talk a few words about the German National Disease Management Guidelines Program. However, I will focus in this speech on quality criteria that are important when you're producing guidelines. This is not a speech about implementation and the impact of guidelines on healthcare. This is due to the simple fact that guideline is not a protected term. And I want to make sure that when we talk about guidelines, we have a common understanding of what good guidelines are. So first, my background is the German National Disease Management Guidelines Program that has been founded in 2002 by the German Medical Association, National Association of Statutory Health Insurance Physicians, and the German Association of the Scientific Medical Societies. It's coordinated through our agency, and they're evidence-based guidelines on highly prevalent chronic conditions, really the major chronic conditions, let's say. We work with large multidisciplinary panels, always including GPs, patients, carers, and other health professionals like physiotherapists or psychotherapists or whatever is important. We have a specific focus on the coordination of care. We want to support individual shared decision-making as well by providing also patient information, and we're to inform the German disease management programs. So this is where I come from. And of course, I think that the guidelines we produce are pretty nice. However, how do I know that? And so let me talk a little bit about quality criteria for guidelines. As early as in 2001, the European Council has had the first idea on how to produce guidelines. So it kind of provided a guideline for guidelines as early as 20 years ago. And you can say that in some of the countries, discussion about guideline development had started in, let's say, the early 90s of the last century. So there's quite some experience on guidelines, and people more and more started issuing guidelines on how to make good guidelines. And one most of you may know, and where Dini has cited from just when explaining what a guideline is this clinical practice guidelines we can trust paper from the Institute of Medicine that was issued in 2011. We have also the Guidelines International Network, which is active since, I think, nearly 20 years or so. And that has issued the International Agreement on Standards for Guideline Production, also more important, and that was in 2012, and in 2015, even more important, the position paper on disclosure and management of conflicts of interest. We then have, some of you may know, the GIN, so the GIN is the abbreviation, the acronym for the Guidelines International Network. We have the GIN and the McMaster Guideline Development Checklist, which guides you through the process. We also have the rights statement that says how you should report guidelines. So we have this, this is only a very small range of pages that I show you here, but I think these are the most important that we work with. And once you're a guideline user and you want to understand what the quality of the guideline is like, you need to assess a guideline, and therefore you have the agree instrument. And then in the next few minutes, following the explaining quality criteria, I'll definitely follow the agree instrument and some of these items. But if you want to sum up what all these papers came up with as quality criteria, you can say that there are some aspects where there's a consensus, what makes it a good guideline. And that's a balanced panel composition. And I explain why this is important later on. It's a strict and transparent conflict of interest management process. You need a predefined, evidence-based, outcome-oriented methodology. Ideally great, but it could also be something different if you achieve the same means. You need a structured and transparent evidence to decision process. That means once you have the evidence, you have to be very transparent how you come to the recommendation. You need a formal consensus process that ensures that everyone has a say in the guideline process. And you need regular and ideally continuous updating. You see, these are quite some quality criteria, and I have only 10 minutes, so I will focus on 3 of them. And as you have discussed HTA and the systematic evaluation of evidence already, I will focus on 3 other aspects. And the first, which I think is very important, is the balanced panel composition. And what do I think this is important? In the AGREE instrument that I mentioned, the items 4 and 5 say the guideline development group includes individuals from all relevant professional groups, and the views and preferences of the target population, for example, patients or public, have been solved. So why is that important? At first, we have strong evidence that monoprofessional groups tend to recommend in favor of the intervention they offer. Surprise. And they also tend to interpret the evidence in a way that favors their intervention. So even if you're doing a very hard evidence-based methodology and you work only with cardiologists, they will come up with the idea that cardiologic interventions may be more helpful than surgical ones if they look at the evidence. Second, we have moderate evidence that involving patients and or members of the public positively influences the scope, the processes, and the recommendations of the guideline. And third, we have moderate evidence that patients and professionals' value judgments on the relevance of outcomes differ significantly. So you would basically want guidelines that matter to patients. This is why it's important to have them on the panel. The second I want to focus on is the strict and transparent conflict of interest management. Why is that important? AGREE item 23 says competing interests of guideline development group members have been recorded and addressed. That means they not only have been disclosed, this is not enough, but they had to be specific consequences on how people with conflicts of interest were treated like in this group. Why is that important? We have strong evidence from other research areas that financial ties to industry unduly influence research outcomes, and it's very plausible that this applies even more to a process where you have underlying value judgments, as in guideline development. We have strong evidence that financial ties to industries are not always disclosed in guideline groups, and this is terrible for the credibility and legitimacy of guidelines. Which is quite a recent paper. And we have weak evidence on the other side that conflict of interest management may not significantly influence guideline outcomes, and specifically the recommendations that you come up with when other protective factors are in place, like using a strong methodology and a balanced panel composition. So, although we know that conflict of interest might influence research, we are not sure whether it's important to manage them when you are in terms of outcomes when you're in the guideline process. However, it is the most important thing to do for credibility and legitimacy, and I think it's a proxy for a panel that is also willing to accept the strict methodology and accept transparency. So this is why it is important. Third, I want to point out the structured and transparent evidence to decision process. Why is that important? Here you see again the AGREE item saying methods for formulating the recommendations are clearly described. The health benefits, side effects, and risks have been considered in formulating the recommendations. And there's an explicit link between the recommendations and the supporting evidence. Why is that important? That is important because formulating recommendations is based on a series of collective value judgments that the guideline panel makes. And these are value judgments about, for example, the importance of the outcome, the certainty of the evidence, the relevance of wanted and unwanted treatment effect and their balance, the potential to improve healthcare outcomes, and the accessibility and resources, and questions also like equity, and so on. And here, the great working group offers a structured process to collectively make these value judgment and to make them transparent. And this is even more important when you're not based on a good evidence, but when evidence is weak or sparse. Because when trials are lacking for a healthcare problem that needs guidance, the collective experience of your panel, which is multidisciplinary and has a broad range of experiences, the best available evidence. And this is why transparent evidence to decision becomes even more relevant. And the great working group, again, provides guidance on this aspect for guideline panels. And the one among these issues when you should think about making a good practice statement is there a well-documented, a clear and explicit rationale that is connecting all the indirect evidence that you have. That means the knowledge of your panel and maybe knowledge about epidemiology, knowledge of outcome of other care options that you have as an alternative, for example. So here, when you have no direct evidence, it's even more important to be transparent. Yes, so basically these are three factors that, among a lot of others, make up good guidelines. And this is what I think we should talk about when we talk about guidelines. Guidelines that are evidence-based, that are outcome-oriented, that are done by a panel that definitely reflects all the different views, that include patients, that have a transparent conflict of interest management, that have a transparent evidence to decision process. And I think I will link to that later on, that are continuously updated. So yes, thank you. That was my 10 minutes, even 11, I see. We will discuss questions later on, but if someone is interested, you can also contact me directly via mail. Thank you.
Thank you very much, Corinna. I hope colleagues had the chance to see your email address on the slide, and if not, we can always put it in the chat box as well. I think very important to highlight what you said early in your presentation, that the presentation focused on, let's say, how guidelines should be developed, not how they can be implemented to influence care. And I think when we were discussing our chapter for the book that I mentioned in the beginning, we were exactly thinking about the way that the guidelines can influence care in a positive way towards quality of care is if they are high quality themselves, right? So I think the three big issues that you just mentioned, really big contributors to making sure that we have guidelines of good quality that then influence care in the right direction. Let's put it that way, even if it's quite a normative thing to say. Thank you very, very much. I think we will have a number of points to pick up on in the discussion later on in the webinar. Erica, can I ask you, before we move to the first spotlight and to Sophie, to share with us the overview of the poll results, please? Thank you.
Hi there. So, very interesting with the poll results. Most of the people are working in countries where they do have established guideline development programs, but there's still 27% of the respondents say that they don't. So that's potentially something that we need to bear in mind in the discussion. A quarter of the people here have, in the course of their professional career, have done all of the above. So they've used clinical practice guidelines to make clinical decisions and to inform other types of work, and developed clinical practice guidelines. But of these different things, most frequently people have been using clinical practice guidelines to inform other types of work. So that's very interesting and very useful, and we need to bear all this in mind in the discussion. Thank you very much. Thank you.
Thank you, Erica. Indeed, I'm picking up on the last point you made on the 40%, which is the leader among the options. So using clinical practice guidelines to inform other types of work. And we put a couple of examples of what these types of works could be. And I'm sure our participants also used clinical practice guidelines for other types of work, but thinking about developing or updating, for example, quality improvement indicators, which is another clear link to quality improvement initiatives, or the link to health technology assessment with clinical guidelines and HTA sharing a methodology, I think is quite a contributor here. And of course, we use them also when we think about publications and recommendations for other things as a good summary of where the evidence is on the issues that they cover. Thank you very much, Erica. And with great pleasure, let's move to our first spotlight speaker, Sophie from HAS, to give us a perspective from France, but also from your professional experience so far. Sophie, over to you.
So thank you so much for inviting me to participate to this fantastic webinar. So the next 5 minutes come, I would like to tell you about challenge we are faced to join force to improve quality of care and what are the opportunity that might be great. So we start with HAS and move after for Jean. HAS is the French National Authority for Health with 3 clear missions. So HAS assess and embrace health technology, HAS recommend and elaborate CPG, HAS measure and improve with accreditation process. So all the 3 parts of quality of care are covered by HAS. So as a public independent body, we face with a challenge that everyone in IBM will face. First, by their very nature, guidelines are evidence-based, and all providers know the real and pragmatic constraints between quality versus rapidity. The issue are shared through the evidence-based area, and the world is changing. So many changes in the recent years. The most fabulous one are to integrate the new digital world, to develop common norms and standards, and to create and maintain up-to-date recommendation by a living process. So the pandemic also was a big, huge challenge to produce up-to-date, rapid, and trustworthy guidelines to ensure guidance for health decision. Facing such a global crisis, guideline developers have to adopt new methodology, especially in managing and pandemic, in using real-world data, in sharing a recommendation on digital platform, and also in developing living evidence-based guidelines. In this period, HAS adopted a living guideline process for providing rapid COVID guidelines specific to the pandemic context. We perform a 7 steps, a simplified method including key elements to accelerate the process. And during this period, more than 100 response rapid and advice were provided in less than 2 years. So next step is to assess not if, but how this process be relevant to other domains requiring prompt decision-making and how to manage the resources and costs need to do it. Perhaps if we accelerated a collaboration between actors, and here we are to go to Jean. The Guideline International Network is a global network of organizations, more than 100 organizations as HAS, but also individual members interested in evidence-based guidelines. Jean was created in 2002, and our vision is trustworthy and accessible guidelines for better health. Our mission to lead, strengthen, and support collaboration. 3 main are providing a network and partnership, assisting members in reducing duplication of effort, and also promoting best practice through the development of opportunities for learning and building capacity. So, in line with this Jean's aim of encouraging collaboration and reducing duplication, the third Jean library was updated in 2019 to become a Jean library and a registry of guidelines in development. It's free to access, and to this day, the Jean library and registry contains more than 3,000 guidelines you can access. Jean members could also be involved in different specific working groups in their field of interest or in one of the 7 regional communities. In addition, Jean provides opportunities to access tools and training in the guideline field, the Jean Master Checklist, we are already, the last recent ones are the INGUI training program with 4 levels and the Jean Public Toolkit. At least, the last opportunity to start collaboration and exchange is to attend the annual conference organized by Jean, and I hope to see you in person in Toronto in September. So I really hope I have succeeded in convincing you of joining the GIN network as one of the current opportunities in the field of guideline to improve quality of care. Thank you.
Thank you very much, Sophie, for this really comprehensive presentation, which you somehow magically managed to do in 5 minutes. This is amazing. Thank you very much. I think I will be really interested to come back to you for a number of points later on in the discussion, and particularly on this issue of having within HAS HTA and also guidelines and also quality indicators. And I might ask you how and if colleagues working on these different areas work together, or how the work then overlaps. But not now, because now we go to Gianpaolo for your presentation, Gianpaolo, that takes us to the European level for clinical practice guideline development. Over to you. Thank you very much for joining us.
So, hello everyone, and many thanks to the Observatory for the appreciated invite. I will be presenting the European Commission initiatives that are coordinated here by the European Commission GRC. And I will be mainly focusing on 2 initiatives, one on breast cancer and another one on colorectal cancer. The aim of our initiative is twofold. First, to improve the quality of cancer prevention, screening and care. And second, to reduce the inequalities in accessing cancer services across Europe. Our role is also to serve as a standard both for health policies as well as for from a methodological standpoint to the 27 EU member states, but also beyond. Our initiative have 2 main components. The first one are the evidence-based guidelines, and then we have also a quality assurance scheme that aims to provide breast cancer services with the requirements if they wish to improve their quality. So the European Commission initiative on breast cancer was started in 2015. We had 70 participants between experts and patient representatives that have been working in 2 groups. The first group is called the Guideline Development Group, that over the years has issued 74 recommendations on screening and diagnosis of breast cancer. The second group is called the Quality Assurance Development Group and has produced 86 requirements for breast cancer care that can be found in our manuals meant to be used from breast cancer services that can be downloaded using the QR code on the right-hand side of the slide. Another component of this initiative is also a repository of international guidelines on breast cancer care, which were pre-appraised before getting published on our website. The main feature of our guidelines, for sure, is the use of internationally recognized methodology and a very strong evidence-based and transparent process. We have a strict policies when it comes to conflict of interest management, and we are based on the Guideline International Network principles. We did involve patients, advocates, and stakeholders during our development process. We also produce a women version in lay language of our recommendations that are adaptable and implementable, as I will show you later. Our guideline development process is very similar to the process described in the Jim McMaster checklist. Here I presented with the diagram. We use the GRADE approach to rate the certainty in the evidence, as well as to determine the strength of the recommendation. And we do use the evidence to decision frameworks to facilitate decision making. We also have an updating strategy that is used to prioritize the research question that should be updated. The COVID-19 pandemic didn't slow down our activity. In fact, over the last 14 months, we did update 7 healthcare questions on hot topics, such as the use of digital breast tomosynthesis. We actually also issued 2 new recommendations on the use of artificial intelligence in mammography screening that are going to be published soon on our website. As I mentioned, our guidelines recommendations are adaptable. We had a very good uptake of our systematic reviews as well as the guidelines. We are about to launch another big initiative called ECICC, European Commission Initiative on Colorectal Cancer. The aims are the same as the breast cancer one, but in this case, we will be using a single multidisciplinary working group. I present with the scope of our initiative, which goes all the way from primary prevention to palliative care. A part will be covered from guidelines developed by the Commission, whereas the entire scope is going to be covered by the quality assurance scheme. We will be introducing a few novelty in terms of methodologies, including an integrated approach for developing guidelines and quality assurance. We will be heavily relying on the development of analytical framework to prioritize healthcare questionnaire requirements. And again, we will be relying on the GRADE approach, the ETD framework, and the software that we use, it's called GRADE Pro. Again, the CICC guidelines will be regularly updated and easy to be adapted and hopefully implemented. Thank you.
Thank you very much, Gianpaolo. We lost you for a minute, your connection. We found you then, so maybe, I don't know, we will do our best in the video that we will upload to YouTube to have all the content.
I'm sorry.
No problem at all. So the one thing that I might come back to you on in the discussion is this idea of adaptation and the development framework that you mentioned, because I think we have also a number of participants from context that might be interested to see how they can adapt clinical practice guidelines, but we come back to that during the discussion, if okay. So thank you very much, Gianpaolo. This is really enlightening. And we move to our last spotlight speaker, Per, to give us your insights on how we can move fast with best possible evidence, living guidelines environment, and how you do your magic, basically. Over to you.
Thanks for inviting me. I'm Per Van Wyk. I'm a general internist based in Oslo, Norway, but in this context, I'm one of the founders and the CEO of Magic Evidence Ecosystem Foundation. It's a nonprofit, and the picture shows where we started 12 years ago, trying to solve key challenges with guidelines, but also making use of these advances in standards that Corinne took you through, and methods like GRADE, and also technology. So the goal is to make sure that clinicians and patients, as you can see in this picture, can make well-informed decisions at the point of care, even using decision aids for shared decision-making. So I'm going to talk about a breakthrough for living evidence and guidance. And you all know about the COVID-19 pandemic and infodemic, more than 700,000 scientific publications so far, more than 5,000 randomized trials to test interventions ongoing. Now, we also know that most of this is waste. But it's also very reassuring to see that there have been great advances in trials, such as the platform trials, and then for the topic of today, living evidence and guidance. This picture just shows the spread of trials across the globe ongoing. And in December 2021, some of us, having worked to move to living evidence, published a paper in Nature, and I really like this cartoon, showing this big friendly giant taking all those papers from the desk of researchers all the way into the hands of clinicians and policymakers. Only thing that's missing here, I think, is the patients. But this is what I'm going to talk about. How could we arrive at this new era of living evidence, which I think is here to stay. And that's my key message of my presentation. This picture just shows why or how guidelines were updated before the pandemic. It typically took between 3 and 5 years. In 2018, the first living guidelines were published in a platform called Magic App. It's an authoring and publication platform to author and publish and update guidelines. So we published living guidelines for stroke, and the time it took to update those guidelines were roughly more than a year. And at the bottom, you can see what happened through the COVID-19 pandemic, where we come down to 20 days from a trigger trial publication to globally disseminated, trustworthy living guidelines, open access. This picture shows the vision of our Magic Evidence Ecosystem Foundation. And wouldn't it be great if you are at the left in this circle, and if there's a new trial or a study published that is important to clinical practice, somebody would transform that into a updated systematic review, even a network meta-analysis where we compare all treatments against each other in a week. And then that evidence would flow into the hands of guideline panels, meeting online, and the week after, creating these trustworthy recommendations. You could even add HTA at this step. but we're focusing on guidelines now. And then this guidance would be disseminated worldwide to all the target audiences within the next few weeks. Of course, the topic of your series in this webinar is improving quality of care. And we just have to remember that guidelines are more or less useless if they don't have an impact on care. So we have to really integrate the guidelines into electronic health records and registries and pathways and quality improvement initiatives. And we have to produce new evidence, which makes this a learning health system. What we've done in the COVID-19 pandemic from MAGIC is to support WHO and others in producing these living guidelines. So we have teams of people doing systematic reviews, around 50 people at McMaster, doing daily updates of the evidence. This evidence feeds into the guideline panels from WHO and Australia and NICE. And we also publish the WHO living guidelines for COVID-19 in the BMJ. So we made quite a lot of progress, but it is really important to remember that unless we have an impact on care, it doesn't much matter. So now we work with WHO in particular on adaptation, translation, and implementation efforts in the member states. So we have to make sure that this loop works better. We come about halfway, I think, at this stage. Oh, did I break up?
No, we can hear you. I think everyone is just very focused on what we're talking about.
Okay, good. This picture just shows the infographic in the BMJ. It exemplifies how we could present recommendations in a more user-friendly format. And then if you click on the guidelines, you will come to, for instance, the BMJ, and you could really drill down. You have all the drugs and alternatives here. So I'm interested in molnupiravir, which is a new drug. And then guidelines should provide more details. So here you could click and find more. This is a weak recommendation. We suggest this treatment in those at highest risk of hospital admission. And you'll find these great evidence summaries with the benefits and harms. And you can also click and find decision aids if you want to share this with your patient. Now, for the sake of time, I'm just going to end with showing also how guidelines need to be available where clinicians and others go. This is the Australian portal where you have flow charts and all sorts of information about what's new. And you could click and go straight into the platform MAGIC app to find recommendations and then drill down. This is the NICE portal exemplifying their new strategy for the next 5 years. I think they are really spot on. They will move to dynamic living guideline recommendations, but also then focus on impact. So I think this is where the field of guidelines is moving. And I think we made some great progress through the COVID-19 pandemic, but definitely remaining challenges that we can discuss in the remaining part of this webinar. Thanks.
Thank you very much, Per. I think as you highlighted and as we discussed a little bit earlier, these are two very important things. Guidelines have to be well done, but they also need to be accessible to those who need to use them. Otherwise, impact on quality of care cannot materialize, basically, right? So these are both very important elements, and we pick that up, as you said, in the discussion in a minute. So thank you very much. I will go briefly to Erica now to give us a little bit of an overview of what's been going on in the chat, and then come back to our panelists to have a little bit of a discussion, weighing in on what our participants want to find out about. Erica, over to you.
Thank you very much, Dimi. It's been a busy chat box, and thank you to everyone who's been sharing resources. One of the questions that has come up is around patient advocates in the development of guidelines. How can we achieve that? And do they need training? But also, what do we need to watch out for in terms of what in the chat box Jelka called Trojan horses? So the AstroTurf organisations, patient groups who can sometimes be promoting the newer treatments as the better treatments when that's not necessarily the case. So that sort of thing. There's also quite a lot of interest in how guidelines can work for multimorbidity, and how can guidelines take into account the complexities around multimorbidity. Really interesting question from my colleague Marina. who asks about whether or not the absence or presence of guidelines and work on clinical guidelines, whether or not that can be used as a measure of overall quality of care or health system performance, or do we need to look more at something like implementation? And then people are also asking about how can we make guidelines more accessible to lay people, the actual patients, even if they're not the sort of like, as it were, end user of such guidelines. So yes, I've got some more questions as well. So hopefully we'll get a chance for another round. Thank you.
Thank you, Erica. These are, I think, 4 rounds already, as far as I can tell. So let me weigh in on that a little bit. So we have question number 1 being involvement of patients, and I think we already talked about this a little bit last week, but very important this week as well. Question number 2, and you will help me, is multimorbidity. So when we have to deal with guidelines that have to look with guidelines in general, we need to take into account that for some patients, or many patients, an increasing number of patients, we have several conditions to think of at the same time. Then we have this issue of, does guideline activity mean quality of care? And I think this we more or less answered in different ways, but we can come back to that. And then the final one, Erica, was what? Sorry, this is the one that I don't have anymore.
It was on lay accessibility of guidelines.
All right, exactly. So if we look at all the nice formats that Per showed us at the end, which are already a very big jump forward compared to the very long PDFs that some of us are used to, then we also need to think about how we make that accessible to patients. And I think for many of us here, there are initiatives that are working in this direction under the concept also of shared decision making. Let's see how far we get in the discussion and if we manage to pick that up. And I will add my question on different departments on HTA guidelines and quality indicators working together, which we saw a little bit of both in Sophie and in Giampaolo's presentations. So let's start, I think, with the patient involvement. This is a really, really important point. I will start with Corina, not because she's our keynote speaker, but because she gave us the standards for guideline development. And then perhaps we move to Giampaolo and then to Per and to Sophie at the end. Corina, over to you first. Patient involvement, where are we? What can we do more or differently?
Well, this is such a broad question that, however, I've been chairing the patient and public involvement working group of the Guidelines International Network for nearly 10 years, and I can say we've definitely made some progresses. However, the question, how do we involve patients and aren't they a risk, as accompanying our work since the very beginning? And very funny, is nearly all people looking at guidelines are asking, is it a risk to involve patients? And nobody asks, is it a risk to involve doctors? And we must say the potential of having a conflict of interest is, or the risk of having a conflict of interest is much larger in healthcare professionals than in lay people. On the other hand, it's very important to assure a working process and a framework where patients have the chance to understand the process, understand what's going on, and daring to speak up. That means if you're definitely dedicated to involving patients and carers and related, and so in guideline development, as in other areas of research, it's important that you offer them training and support. Training means the intellectual ability to understand what's going on, and support means acknowledging their being a patient and having, for example, specific needs, and also understanding that jargon is not helpful to be used. It's not helpful to discuss titles and how you address people. So it's important to ensure equal standards for everyone. And it's important to have for each group member and for all group members the same and transparent conflict of interest management that comes in place. And once you have these standards, it's perfectly fine to have patients and other members of the public on guideline groups, and the experience from different countries shows it works. However, that is resource demanding, and you must know that. And you have other chances. You can use surveys, you can address, let's say, patient organizations also, you can use focus groups, you can do a systematic search of qualitative evidence to understand what matters to patients. So you have a variety of methods to ensure that patient views have been taken into account.
Thank you, Corina. And I think let's link this question before we go to our other speakers with a lay output formats, as Erica put that, or lay dissemination formats, because a lot of the things that you're talking about also require that the content is in a format that patients and citizens can understand. So maybe perhaps a little bit more on this before we go to others?
Yeah, it's fine that you just that, Dimi, because in our June working group, we have this concept of patient and public involvement that comprises 3 strategies. The first is participation, saying you have someone on the panel. The second is consultation, as I said, doing surveys, seeking input from a larger group. And the third one is information. That means conveying the content of a guideline to the public. And this also includes like lay versions of guidelines. And then there are guideline programs that offer complete guidelines in a lay version so that everyone can access them and understand what's written in there. Others choose to focus on specific recommendations and translate them into either decision aids or lay versions of the recommendations. And others focus on translating all the recommendations into lay language and not so much focus on the evidence that's behind. So there's a large variety of efforts to ensure that people can access the content of guidelines. And yeah, I think there still remains a lot to do, because this is also quite resource demanding, and we see that the large guideline organizations do so, like NICE, for example. You offered a complete structure on how to access guideline information in a very understandable way. But smaller guideline producers will have some difficulties to provide all these formats.
Thank you very much. And I think if we have resources in the direction of guidelines on how to do guidelines for lay people or for a broader audience, I think this is also something we can paste in the chat as we move forward. Gianpaolo, let me come to you, because you mentioned in your presentation briefly about formats for patients. So maybe just to reflect briefly from your work, are patients involved? How are patients involved? And how do you address this issue of...
Absolutely. I completely echo Corinna's discussion. And this is what we do in this European Commission initiative. Also in my previous experiences, all these are patient-centered initiatives. And usually you include in your panel of experts 1 or 2 patient representatives. So in this case, we had women who suffered breast cancer. In other experiences, there were experiences on autism spectrum disorder. There was the mother of a kid with autism spectrum disorder. There was the kid itself. In adults, there was a person with Asperger's syndrome. In a prior experience with Society of Hematology, there was a person who suffered a pulmonary embolism. And it's key, the participation of patients, because they can provide an insight and their own experience. Also, as part of the systematic review that is conducted, usually there is also a great effort put on to the values and preferences of patients. So it's the view, the perspective, the presence of patients, it's just key. And we also, as Corinna mentioned, involve patients in different phases of the development. For example, you could ask stakeholders, including patients, whether the list of questions that are going to be included in the guidelines is okay with their opinion, or you can ask their comment on a draft recommendation. So it is key, and also the dissemination has to be targeted on patient. It is not easy, but there are researchers focusing on how to translate guidelines in lay language. The McMaster University has done a lot of work on this, and it's not easy because our work is quite technical. So, for example, my team leader always tell me, Gianpaolo, look, I understand the strengths, the rating, the certainty, but this is something that my daughter, my husband wouldn't understand. So we always make sure that what we circulate is also in producing a lay version, because otherwise this is going to be a barrier to implementation. So it's key that the lay version of guidelines is available, but again, it's not trivial, because as a matter of fact, you want to you're talking about something that has a large degree of complexity, but at the same time, you want to make it easy to read. So there is a lot of research ongoing, and it's not easy, but it's essential to any guideline.
Thank you, Gianpaolo. And I think the point that you make, that the implementation and successful implementation is very clearly linked to that, I think is crucial at this point. I saw that Per already posted something in the chat, but Per, perhaps very briefly from your perspective, less maybe on what you're doing already, because you kindly provided some input, but what can we do more or differently on this in the future? Thank you.
Yeah, I think it was summarized well by two others. But one thing we came across that is quite important for patients. It's called burden of treatment or practical issues. And we typically tend to forget, what does this mean for me in my life? So we've included these factors in the guideline development, again, for example, in these BMJ rapid recommendations as examples. And it actually has an impact on what the recommendations end up being, because it turns out that this treatment is not acceptable or easy to do for a patient. Now, this is within the great ETD framework as well, but not really focused on the patient. So I think we learned a lot from thinking through and having patient partners in the panels, and they can tell us that this treatment is just not going to be acceptable to them. That's critical information for patients. That's the only point I want to make.
Thank you, and that's very important, and it's not what someone automatically thinks about necessarily as the first issue, if you're not in the daily practice as you are. Sophie, we come to you perhaps very briefly on your experience with this, on patient involvement. I see also you posted in the chat a little bit. Mm-hmm.
Yes, Jean just published public toolkit to offer practical advice and on involving patients in our different production. And also I have to say that HS also include patient in whole production. And in 2019, even we established a public involvement council to bring into perspective to the public and the patient view on all the works we produce. Yeah, I think it's more and more important aspect of our guideline. And we have also to design specific format or products to implement, as Gianpaolo said, guideline for the public. Yeah.
Thank you very much. I think that's very useful, and I also see from the little bubbles popping on my Zoom window that also our participants are very grateful for all the information, for the great presentations, and for the materials that are put in the chat. We have 3 questions still from the previous round, more questions now in the chat, but I will use my moderator's prerogative to introduce a slightly different question for the last round, because we only have 4 minutes left. So I will ask all of you to very briefly reflect on how we talked about how we can strengthen the development quite a bit. So how can we strengthen guideline developments and implementation moving forward to ensure that we increase their impact on quality of care? And I will provocatively say, on the HTA question last week, we had, for example, the proposal or the current HTA regulation, joint assessments moving forward. Is this something that makes sense for guidelines, or are we, when it comes to collaboration, already very well served by the organizations that we have, and we should just strengthen those? So in a way, just putting this in a provocative way, but feel free to take it in any direction that you want. And I think we'll take Corina last for that, so that you can also wrap us up for the day. So I would start with Per, go to Gianpaolo, then to Sophie, and then to Corina. Per, over to you first. Sorry for the abrupt notice. What do you think?
No, that is really the key question for today. And I think the idea of this evidence ecosystem framework is the realization that we work in silos. I think linking quality improvers, implementers to guideline developers and HTA producers is key. And I think the main challenge now for those of us investing our time in guidelines is to focus on adaptation, translation, and implementation. And again, back to GIN, I'm a fond believer in GIN and the network. There are working groups to look at implementation, adaptation with more speed now than before. And I think that's just critical. But again, we have to break down the silos and connect these people. And that's actually quite challenging, but because then these actors have to agree on some standards and methods and processes and tools. And we have to demonstrate that this is possible. That's the grand challenge. Thanks.
Okay, thank you very much. I think very, very well put in a tweet length almost. Gianpaolo, over to you. Your take?
Thank you. Yes, of course, it's implementation is key. Otherwise, the risk is that our guidelines are sitting on the shelves. What we're trying to do is to focus a lot on the monitoring and evaluation part by indicating for each recommendation what are the quality indicators and also performance measures. So a way to measure how for example, the breast service is performing on that very specific indicator. Unfortunately, this field it's not as advanced as the guideline field. There is a lot of effort which is being conducted by the scientific community. So I'm confident that over the next few years, we are gonna make a great jump ahead in terms of integration of guidelines and quality assurance. And then we also have to be creative in terms of dissemination with all these IT tools. There are all these beautiful softwares, and the IT is very helping us a lot, both in disseminating as well as producing timely guidelines using this machine learning and living approach, because otherwise because guidelines are difficult and are expensive, and it might take as many as 5 years to develop a guidelines. So through the IT, we are speeding up the process, and this is also a facilitator for the update of guidelines because we're using something that is updated. Okay.
Thank you very much. And let me just point out, just making the link because you work with the European Commission, that the EU has a number of different support mechanisms, funding mechanisms that we could perhaps use for this purpose. We need a whole other webinar to discuss them in detail, but maybe we will have one. Sophie, over to you very briefly before we end with Karina.
Collaboration, collaboration, collaboration.
Okay, excellent. Thank you very much. I think this is even less than a tweet. Thank you very, very much, Sophie, for that. Karina, to you. Final words on the minute of the hour that we promised our participants. You can take 2 minutes. It's okay. Thank you.
Okay. So I think we have different levels. Level of production, yes, collaboration is key, but I think more important than collaboration is avoiding duplication. And we have concurring guidelines. Why do we have them? We have concurrent systematic reviews. So definitely bringing people together and coming and understanding that we're serving for a common good and not for our own academic interests is important. On the other hand, this is implementation. And implementation, I think the efforts that, for example, UPair and the United Collaboration are doing is raising accessibility and usability of guidelines is important. We have evaluated our guideline program with the end users, let's say physicians, and we learned that it is important that you increase accessibility on the one hand. That means becoming shorter. They say guidelines are too long and all these old documents and all this PDF. I want to access it more quickly on the one hand, and I want to have it in my healthcare information system. I don't want to have my guideline here and all the documentation for the patient there, but I want to have this all together. So it's not only the guideline producers, but it's those who make the rules for the healthcare system to ensure that guidelines can be used in a technical way, but also, and that's much more important, in the way that resources are allocated. Because we actually live in healthcare systems where we get rewarded for making more and more interventions. And guidelines that recommend against interventions are definitely very hard to implement. We have known that from our low back pain guideline that recommends against nearly everything. So it is not only a question of what can we guideline producers do? We can do a lot in making more formats that matter, but it's also a question, how do healthcare systems value guidelines and the other products? And it's great that next time you're talking about performance measures, these can be derived from guidelines. And I think this is an important point. And from the very last thing, if I have a very last minute, when we're talking about living formats, we have also to keep in mind that these are resource demanding. And we definitely must very carefully evaluate whether we do not only help industry implement the drugs, because what's driving research is money. and not really understanding of something. And research is basically based on more interventions that more interventions at a limited effect. So we would definitely need to be careful about that, because having more guidelines, more complicated guidelines, doesn't help implement them.
Thank you very much, Karina. I think very strong words for closing, and a very clear message to the policymakers among our participants and among those who will see the YouTube video. We're very, very grateful to all of you for joining us today, to our speakers and to our participants. Stay tuned next week. The link is very clear to what we will be discussing, and we look forward to seeing you again. And I think very clearly this is a topic that we could discuss for a long time still and not answer all the questions that everyone had. So maybe we will see you soon again with another webinar on clinical guidelines. Thank you all very, very much. Enjoy the rest of your day. See you next Tuesday.